Welcome to the Studio DOHC podcast. I'm Lindsey Valenzuela, the Associate Vice President of Population Health Integration here at Desert Oasis Health Care, and I'm thrilled to be back for episode 5. Joining me today are Dr. Sebti, Dr. Stephen Kim, and Tracy Campbell, who will have a special story to share with us later. Today, we're highlighting the DOHC Stroke Clinic and the importance of knowing the signs of a stroke. But before we dive deep into it, I'll let our guest introduce themselves. Dr. Sebti.
Hello, my name is Sebti. I'm a neurologist. I've been practicing in the desert area since 1999, and essentially both high desert and low desert, and specifically Yucca Valley and Palm Springs. And for the past 10 years, I've been with DOHC, and it's been the best thing that happened to my career because I can just be a neurologist. And then I have found so many resources that have helped me. I believe patient education is very important, and that's one of the things that the DOHC Stroke Clinic does quite well. And of course, we'll talk more about that with Stephen and Tracy.
Okay. I'm Stephen Kim. I'm a clinical pharmacist that manages a stroke clinic. So I'm taking this really unorthodox role as a pharmacist, kind of helping to manage patient after a stroke event. And my professional goal has always been expanding the scope of practice for pharmacists and assisting the patient at the best of our ability within the scope of our license. And it's been a really adventurous and fun ways for me to work with Dr. Sebti, and alongside the support of the PharXM team with Dr. Valenzuela, helping me to create this clinic and then grow this clinic and just be a real success is so far. And it's been a real pleasure and challenge that I really enjoyed so far. I love this clinic, and I hope to be able to translate that into better patient care, patient education, and hopefully prevention of another stroke for my patients.
I'm Tracy Campbell. I have been a medical assistant for 21 years. I moved to the desert in 2015, joined Desert Oasis in 2016. And like you, Dr. Sebti, I'm very thankful I've learned something all the time. And I'm really grateful that I'm part of this podcast because it's both career and a personal. So thank you.
It's so wonderful to have all three of you here. I'm so fortunate to get to work with each one of you every day. And so thank you again for taking the time to be here. The DOHC Stroke Clinic obviously is something that grew out of a need from what patients need after a stroke to educating our entire membership on how to identify a stroke. But I think the first question really that a lot of people have is stroke really a problem in the US? What does that really mean to have a stroke?
I think Stephen has all the answers.
So we went to CDC website to memorize all the statistics. So here it goes. So in the US, it's a real big disease that's very detrimental. So about 800,000 patients in the US suffer a stroke every year. About a quarter of them, about 200,000, is a recurrent stroke. So recurrence of stroke is a very real thing. A patient who had a previous stroke are much more likely to have another stroke. Also, about 80% of these strokes are actually considered preventable if we're treating them optimally. And that's where I kick in so that I can make sure that the patients are not getting any more further stroke that will be more debilitating and potentially fatal for my patients. And also, in terms of the financial cost of things, it's costing the U.S. about $56.5 billion back in 2018 to 2019. And also, it's just a really debilitating disease. And I started this clinic beginning of this year. I already have about 160 patients that I've been following up with closely that I'm needing to manage. So this is a really big disease state that happens very frequently. I'm seeing at least probably one new patient every single day that I need to follow up with, and just make sure that things are all into the right place quickly, because after the first stroke or a TIA, also erroneously sometimes called mini stroke, they're at much greater risk of having a recurrent stroke, especially within the first week to first month and moving forward. So we want to make sure everything gets into place as soon as possible to prevent further complications.
Well, and one a day, that one a day is a lot. So these risk factors that you're talking about must be pretty common within the population. Dr. Sebti, what are these risk factors?
The risk factors are very much the same as for everything else that's vascular, the same as, say, heart attack. And the big offenders are hypertension on top, and then the other known ones, hyperlipidemia, elevated cholesterol, triglycerides, diabetes, and a whole bunch of other ones. And that's one of the things that makes Stroke Clinic very special, because Stephen goes through their whole life and gets to know the patient. A stroke patient is not a stroke patient. Each patient is different, and their risk factors. And Stephen goes through all of these, including sleep apnea, if they have obesity, everything. And I'm sure he will talk about it. The important thing for me has been that when a patient has a stroke, it is a scary event. And of course, we will hear more about it. But the patient really does not know what happened. And they go to the hospital, a lot of tests are run, and then they're discharged. When they come and see me first, I ask them, what happened to you? They said, well, didn't you read my chart? I had a stroke. And then I ask them, well, what does that mean? And they start worrying a little bit. This neurologist doesn't know what a stroke is. So I have to reassure them I'm board certified. I'm associate clinical instructor, professor at UCR. But I want to know what their understanding is. And then put this in simple terms. Look, stroke is when a part of brain is damaged, dies. Well, how does this happen? And you can't, explain this very simply, that it's just like a part of the grass that doesn't get water and dies, and the same thing happened. And then you say, well, why? Why did this happen to this pipe, to this sprinkler? And then once you get them to understand lipohyalinosis, what does that mean? That means the blood pressure is high, the wall of the small arterioles get bigger. That's what happened to muscle when it has to work hard. And then the lumen gets small. And you explain things, in simple ways, and then you buy them in. You do quite a few things. One is that you explain things to them and they understand what happened. Having a stroke, by definition, it comes on suddenly. It's not like patient was expecting anything, they were doing anything. It's very scary, just like being robbed on the street, and it's very anxiogenic. And that's the most important part, that we now have a clinic that Stephen runs, and he can address all of these.
So you bring me to my next interesting question, which is, a neurologist, that makes sense, and a pharmacist. Why the two of those together? What about that team makes sense for the stroke clinic?
In terms of the pharmacy's taking role, so I've been trained here at Desert Oasis Health Care as a resident, and I've been dealing with a lot of patients within the diabetes clinic where they're having a lot of issues with cholesterol, sugar control, and also blood pressure. So I've been having a lot of difficult patients that are having it's called A1C, which is an indicator for high average sugar level. That's around 10%, 15%, when a normal A1C is about 5% for non-diabetic patients. So I've had a lot of training and got to manage a more difficult patient to manage for diabetes and also blood pressure-wise. I had a lot of experience there. And also, we also have a clinic called anticoagulation clinic, which deals with blood clots and giving out the right blood thinners and whatnot. This is all relevant back to the stroke clinic where it all combines together. So in terms of treatment part, the clinical pharmacists here within Desert Oasis Health Care are very well trained to treat all of these disease states. And it was a prime opportunity that Dr. Sebti offered, that, why don't clinical pharmacists help out with these stroke patients? These are all the risk factors that clinical pharmacists are already managing. You guys will do a great job. And the physicians will definitely appreciate all the help they can get so that they can take care of other things for the patient. So that's when I stepped in near my end of residency last June, that I was asked to make this protocol that I believe nowhere else really utilizes pharmacists this way, in this comprehensive manner. That I had this challenge that I had to create this new clinic from scratch, helping and getting assistance from Dr. Sebti and his expertise to make it right, so that we're optimally treating patient and not feeling like we're just bandaging while the patient is waiting for neurologist or primary care doctor. But at the get-go, from having the stroke and day on out, we're following up right away so that they're getting treated right away to an optimal degree in a comprehensive fashion. And I think it's been a wonderful experience, and clinical pharmacists can focus on treatment. A physician, neurologist can all chime in to help with differential diagnosis, where we're making the right diagnosis for the patient with unclear disease state at times. So let's say an example would be something called transient ischemic attack, TIA, also erroneously called mini stroke. Our common theme that there's no clear, oh, this is definitely a TIA case, or this is definitely a hypertensive encephalopathy, where it's a brain abnormality because of very high blood pressure, or is it a seizure case, is it a migraine case? There's different cases that can present with stroke-like symptoms that we need to kind of unwrap. That's done best by the neurologist. So I always ask Dr. Sebti for his expertise and experience to make sure that those diagnoses are done properly. And then I take back the patient to make sure that they're getting the optimal therapy that we just discussed, treating for the modifiable risk factors, like the what Dr. Sebti mentioned: blood pressure, cholesterol, diabetes, blood thinning effect, and also smoking and alcohol use. Those are all key substance use that can also contribute to higher stroke risk, as well as obesity. That's very prevalent risk factors that we can actually help the patients in.
So what I'm hearing is that you're the medication piece, keeping people on their medications to help control those modifiable risk factors. And you're making sure that we're treating the right thing.
I think so. I think we are minimizing Stephen's role and pharmacists in general. One of the things that puts DOHC apart is their medication management. I'm sure you well know that. And I'm a patient here myself, and it was through my own health that I came to see how much pharmacists helped me to get better that I wasn't quite getting from my primary care doctor, who's fantastic, by the way. So then, as I spend more time here, I realized how much they help patients' health. They help patients with high blood pressure, diabetes, coronary artery disease, congestive heart failure, pulmonary problems, and so forth and so on. And what makes this stroke clinic very special is the fact that the biggest problem in our healthcare, and if you talk to stroke specialists, is that we do not have a coordinator. We don't have anybody who gets everything together. And this is what Stephen does. He talks to me. He will contact the cardiologist. He will contact the pulmonologist. He will contact his colleagues in diabetes clinic, colleagues in the hypertension clinic. So he really provides a comprehensive healthcare. And that's why patients love him, because he brings everything together and explains things to him. Unfortunately, doctors are busy and we don't have time, but we need this something to be done. And it's basically invaluable for the patient.
Yeah, I read something the other day that we, of course, live in an area in Riverside and San Bernardino County that has a very low primary care to patient ratio, meaning that we have about half as many primary care physicians as we would need for our population. So it sounds to me like this is really helping to bridge that gap with a unique skill set. And, Tracy's been sitting with us so patiently, and I
Oh
know
no,
it's really exciting to have somebody who actually is a Desert Oasis employee who has been here and seen how this works from her own personal perspective. So, Tracy, welcome again.
thank you.
I wonder if you can tell us a little bit about your experience.
Yes. Well, like I said, I've been a medical assistant, so I've always been on the other side of everything. But my husband happened to call me one day and said, I don't feel right. I have some numbness and I'm kind of walking a little like I'm off balance. So we came into the immediate clinic just to get everything. We ended up with the CT, ended up with the hospital. And yes, he had had a stroke in the thalamus region, deep into the brain. And yeah, your whole world is turned upside down because now I'm on the other side and it's a whole different world. How am I going to get these answers? Because I don't know everything. And so we got everything we needed from the hospital and, Desert Oasis. I mean, I called as soon as here's where he's at. Here's what we're doing. How can we find out? And we got in touch with Lindsey and Stephen. And so we had things set up for when he came out of the hospital and got to the stroke clinic. And yes, everything was explained. Because you're going through this. Luckily, it was not a bad one. Brian can still walk and talk, but his memory and the things that did get affected on his left side, we're still learning about. But we got answers as to, how did this happen and as to why it happened. I mean, yes, it could happen to anybody. His was not related to his heart. His is related to his diet. He's very poor diabetes control, and he's been fighting it for years. Amazingly, he has turned around with all the explanation from the pharmacy. And we saw Stephen first, which I didn't understand, but it was good because it was all explained to us. Here's what I'm going to do because Brian's wasn't his heart and he didn't really have a lot of the effects. Like he could walk, he could talk. It's like neurology, the neurological part wasn't as big as it seemed the health factors that probably caused this. So we were seeing Stephen, and then finally Stephen was like, we had questions that he wasn't sure of or whatever. And we recently just saw Dr. Sebti, who explained even more as to why Brian's stroke happened. And a lot of it is the diabetes and the sedentary lifestyle and, things that now we're changing. And then we're back with Stephen. They do talk to each other. Stephen, we would go to appointments. He would say, okay, I've talked to Dr. Sebti. This is what the plan is. To have this available, it's priceless. And yes, what Desert Oasis does with the pharmacy, as Dr. Sebti said, your primary care can do so much, but it can only do so much with everything, like you said. And to have this available with cardio, I had that with my dad. Thank God cardiology was here. We saw him. It was just easy. Everything is on one campus. You can a lot of times schedule appointments so that we've got a lab, we've got, wellness. There's so much here that I mean, as an employee, as a patient, as a spouse, I'm very pleased that I feel very blessed and very lucky to be part of all of this. And I am thankful, so thankful for the stroke clinic because it has been a lifesaver.
Oh, that's amazing. I'm so glad you've had such a wonderful experience.
Yeah.
And I think we work together every day.
Yes.
You and I talk every day. And you know how the operations run and what's expected when you're in the hospital, when you leave the hospital,
Yes.
what's supposed to happen when you go home. But of course, Brian has never been exposed to any of that.
No. And he really questioned, why are we doing this? Why do we have to, how come I have to? And it was like, these things have to take steps because they're trying to find out. And then to try to explain to somebody who now is having memory issues and doesn't. So it's that frustration of having a stroke and what's going to happen now. And for the first month, a lot of it was, it's going to happen again. It's going to happen again.
Mm-hmm.
And it's like, well, but we're doing things. We're working with Stephen. We're working with Dr. Sebti. So, I mean, his sugars and are down. It's unbelievable. The things that, and he even was saying, well, we shouldn't this. He's checking salts. He's checking. It is like such a turnaround that I am.
He's a new person.
He is a very new person. And I'm so thankful because a lot of times when I can't, I think a lot of times he thinks with me as a medical assistant, well, why can't you answer the questions? Well, I don't know all of it, That's why I can go and ask questions or, okay, write these things down when we go in, or I send Stephen an email, here's what happened. What do you think? Or just, can we talk about this at the next appointment? So yeah, it is seeing it from this side, not being the medical person, and how that the person that's had the stroke handles things and the questions that come up has been, it's eye-opening.
And I don't know if you pointed out or not, but Brian is your husband who had the
Oh,
stroke.
I'm sorry. Yes, it is.
And Brian had every right to be afraid and ask questions. And
Yes.
that's very typical because, as I said, these patients get depressed. They are
Yes.
very scared. And then, just like you said, what has been wonderful here with Brian, Steve spent time and explained things to him.
Yes.
And now he has become such a health freak.
Oh my gosh,
which is-
it is. His A1C was like 12 and 13. It was so bad. And he just thought, well, I can take a shot of insulin and it's going to be okay. And now he's staying within 70 to 75%. His numbers are staying where they're supposed to be.
Isn't it amazing that he knows
Yes.
where he is? He's so aware now that he's
Yes.
70 to 75%. And I think you said something really valuable that's, you don't have all the answers.
No.
And I think that's something that this clinic really exemplifies. Stephen doesn't always have the answers. Dr.
And he's-
Sebti may not always have the answers about
Exactly.
certain things, but this team brings everybody to the top of their knowledge base
Yes.
to communicate it.
And they told us, he goes, I'm not really sure about this, but I will discuss this with Dr. Sebti. Because, because Brian was like, well, and like I said, I write everything down because as soon as he walks out, a lot of times he doesn't remember what we discussed.
Yeah.
And so, okay, here, remember we discussed this and oh, that's right. And so then it's been so helpful because he's, wow, because we explained where his stroke was. And then Dr. Sebti went into it a little deeper. He goes, well, that makes all the difference in the world because where Brian's is deep in the brain in the thalamus is where everything comes in and then is sent out to the body. And so that's why a lot of his detriments or whatever are happening because it's still getting mixed up in there because that can't let it go like it used to. And so now that I think he seems a little calmer since that appointment, which is good because I think he's got a better understanding too of, oh, okay, now I really understand, okay, these things, it's not working coming out as it used to, and it may not, but I understand why a little better.
Yeah, I'm sorry to jump in again,
No, you're
but
fine.
the big picture here is that now we are preventing Brian from having another
Yes.
stroke. That's the big picture. This is a preventable disease.
Yes.
And as you pointed out, Lindsey, if we know the risk factors and control them, this doesn't happen. And it's a bad disease. It really makes people disabled and have a lot of
Yes.
deficits that they're not obvious. They may be walking okay. They may be,
Yes.
their strength is okay or sensation, but they have a lot of deficits that are not obvious. But that's how brain is, very complicated. We can prevent this.
Yeah, I think that's a really important delineation that the clinic doesn't exist completely to stop the first stroke. We have a lot of other programs that are designed to stop those strokes, to mitigate those modifiable risk factors like blood pressure and cholesterol and diabetes. But this clinic really strives to avoid the second stroke because we don't know what the outcomes of that might be, right? Could you have a stroke and have certain outcomes and then have a second stroke and have completely different symptoms?
Yes, absolutely. And these people who had a first stroke, we know they are at much higher risk of having another one. And that's why it's so important. This is our chance to intervene. We get them right after the first one and make them understand when they basically are fresh and not educate them and then prevent the second one. But we do work, like I think Stephen was pointing out, that we are not a university center. We're not scholastically interested in the patients. If a patient has on the MRI has symptoms that they have had small strokes in the past, even though these what we call silent, meaning they don't have any symptom, they still go to Stephen. And he basically manages these people. So we are very conscientious about preventing stroke.
Now, Stephen, when you get these patients who maybe had a silent stroke or a TIA or something where they now feel back to normal,
Mhm.
is your treatment plan any different for them?
So I would have to go in deep, whether because a lot of the times the complication comes with potential dementia in the later on, like vascular dementia or mixed dementia cases can happen from these as part of lacunar infarct or the silent stroke that happens to a lot of our elderly patients that I see. So I still let them know this had happened. So because they didn't have a sudden drooping of the face or like one paralysis or weakness on the leg or arm, they're like, I'm not sure if I had a stroke. So I need to kind of explain to them the seriousness of this and that they're still at risk of having another stroke. We're seeing some changes within your brain that could put you at higher risk of having another stroke, something called small vessel ischemic disease. So I let the patient know of all these risk factor and take time to answer their question so that they take the right step. Because just because I treated the blood pressure, cholesterol, and diabetes at age of 80 or 70 does not mean that we can reverse all that process that was done already. So it's a chronic disease. If we leave it longer, it is a cumulative effect. It's like smoking. If you smoke longer, you're gonna have worse outcome. Just because we treated those other condition at age of 80 does not mean that you're back to your 20s or 30s before you had those disease. So we need it's faster we treat these in the 50s, 40s, and 30s, the better the outcome will be in the 80s. It's not something that we're doing it for the health right now. It's for the next 5, 10, 20 years that we're looking into and we're treating these. So we need to take action now if we really want to have you strive and thrive within your life for rest of the remainder so you can live healthy. So yeah.
So essentially, if any of us are facing any of these modifiable risk factors, high blood pressure, high cholesterol, diabetes, and we're in our 20s, 30s, 40s, it's really taking care of those now is an investment in the future to avoid some of these things or to maybe delay them a little bit longer. I was reading an article from the American Heart Association, the AHA, and of course, Desert Oasis has a really strong relationship with them. And one of their campaigns is The Life is Why. They talk a lot about stroke, but they're the American Heart Association. So what's the connection?
Actually, you're absolutely right, because stroke is a vascular disease. So it has been actually not under American Academy of Neurology, really. It has been under American Heart Association. It's a subdivision of the American Heart Association. Because just like what you said, those risk factors that you mentioned, we can sit here and talk about every disease that you want and show you how these risk factors become the cause of that disease. For example, let's talk Alzheimer's disease, right? That's something that everybody's scared of. And now if you go and ask the top behavioral dementia specialist, what can I do? I'm in my 30s, 40s. What can I do so I don't get this disease? They'll say exactly the same thing. Keep your blood pressure under control. Keep your cholesterol under control. Make sure your diabetes is in control. Exercise. Get engaged. And these are all the things that help us with preventing heart attack, stroke. So these are very related to each other.
I had a professor once who said, everything is about your endothelium. Everything is about those blood vessels and keeping them clean, keeping them elastic, and all the things you mentioned do those things. So it's good to know that we're connecting with the right organizations to help with all of those things. Some of the other things that they talk about on their website are ways to spot a stroke. And I know there's a couple of different acronyms. Maybe we can go through a couple of those.
Okay. So some of those classical signs and symptoms, there's an acronym called BFAST. So B stands for balance, E stands for eye. So if there's sudden balance issue or dizziness and also vision changes, that's a non-specific signs and symptoms of stroke. That's amongst hundreds of different things that could cause that, but more classical signs that are very specific for stroke includes one-sided weaknesses or potentially paralysis. So facial drooping on one side. If the patient was asked to try to smile, they'll have one-sided drooping like this and not be able to move around one side of the face. And also not being able to have the arm being able to held up like this, and they'll have the one side drift down if they're asked to hold their hands like this and they're close their eyes, because their brains on the one side is not really getting the blood supply that was needed for them to do that. So F stands for facial drooping, A for arm or leg weaknesses, and and the S stands for speech or slurred speech, trouble with understanding or speaking coherently or repeating what a simple sentence that someone else can say. They won't be able to repeat it all of a sudden. If you see another person or family member that's having these kind of symptoms, especially including one of those classical signs with one-sided weaknesses, plus 2 or more, definitely try calling 911 so that they get to the emergency room immediately for the right imaging testing and the right therapy like clot buster or what's called thrombectomy, where they're pulling out the clot so that they can really preserve what's left of the brain tissue without having them go through an infarct or a brain tissue damage or death.
So T, what is the T?
T is for time to call 911.
Time to call 911. So what is the time frame? Because I've heard people say time is brain. So what time limit are we looking at? How fast should we be?
So in terms of the clot buster, generally speaking, it's less than 4.5 hours since the symptom onset. Could be less than 3 hours for a few patients. And thrombectomy depends on the center, so I can't speak. I'm not.
Yeah, no, you're right. And then initially when TPA came, it was like 4.5 hours. Then it went to 6-7 hours. And now there is data that if there are certain findings on the CAT scan, even up to 24 hours, meaning that these people who wake up, they can qualify for TPA. And thrombectomy is even longer, even within 24 hours. The CT that they can get in the hospital, including the CT angiogram, is very helpful. Stroke is not a painful condition. It's not like heart attack. So patients say, oh, I'll go to the doctor tomorrow. But we can't do that. Stroke means right now, time is brain, and we need to get blood to that part of the brain so less tissue dies.
So really, this is a lack of blood and oxygen to that area, some area of the brain, for whatever reason.
Yeah. 85% of strokes are just like that. We call it ischemic. That means just the blood didn't get to that area. And then we can talk about, was this because of a big clot that came, say, from the heart or aorta, or this was because of damage to the small blood vessels. 15% of the time, it's a different kind. Well, we call hemorrhagic. That means there is a bleed into the brain. And by far, the number one cause that's very preventable is hypertension. And again, the culprit is the same, and we can control that.
It just takes paying attention. Mm-hmm. And, this is important for family members to know as well, because have you heard about patients who have experienced these symptoms and don't know they're experiencing them and have been told by a loved one? Does that ever happen?
Yes, definitely. Just about 2 days ago, I had a patient call in to their primary care doctor asking, I'm feeling numbness and I can't really move one of the right leg and arm as well. Like, what's going on? So I actually had to call that patient yesterday to get him started on aspirin at least and get some diagnostic imaging so that he's getting the right appropriate follow-up to see if it's really a stroke case or other cases. So, and this wasn't as well recognized until the wife came in to see him. Oh, like your facial looks are a little weird. You're having a little bit of slurred speech. So bystander or family or friends are definitely very important that they get also educated on stroke signs and symptoms. So I always make sure that all the caregivers are also educated on the disease state and what to look out for, so that in case, in an unfortunate circumstance that my patient has another stroke, which can happen, I can only prevent up to 80% as best as I can. If that happens, that they get the right therapy and the help so that they can preserve what we have.
So it sounds to me like we need to focus also on educating the family members. I know we have quite a few bits of information on our website, mydohc.com, where we talk about the stroke clinic. We talk about what sort of things we should be paying attention to. These are, spouses, children, friends. We all play a role.
Yeah.
And we also have a link to the AHA and all of their resources on the website. And there's actually a heart walk, an AHA heart walk coming up in fall. So that's another good opportunity to go out, get some exercise, which is good for all these risk factors, and also to learn a bit more as either patients or caregivers or as clinicians.
And like was talking about the symptoms, they're not always real clear, because with Brian, so he called me from work. I was at work, and he says, he says, I think I got a little numbness. He goes, I'm just not sure. And I said, well, let's call 911. He goes, well, no, I don't think it's that. Well, he has neuropathy from the diabetes. So a lot of times he'll get that numbness. So I drove home, which we're only 10 minutes away. He could lift his arms, he could smile. All of that was clear. It was that his left arm had a little bit of numbness to it. So we didn't know was that. So we went to the IC. They checked him out and everything. Well, we're going to get a CT. By the time we went and got the CT, by the time we got back, we hadn't been back probably 2 or 3 minutes. And the doctor there said, I've called 911. He was taking his left arm, trying to get to put his finger, and he could not. His neurological effects had changed that much just from the time even from the time we had got the CT and got back in there.
Wow.
It was amazing, the difference. And I was like, what are you? And he goes, yeah, look. I mean, it was just like there was no control over it. And and the firefighters, are across the street, they were there right there, and he was on his way.
Wow.
But he was not, and like I said, he had a little balance, but nothing. He could walk. So there was none of those we lifted his hands. It was just strange. And I thought, maybe it's some of his neuropathy. So if you're not sure, call 911.
Well, and I think that's a really important point. You knew where your resources were. Our immediate cares have emergency room trained physicians who have seen this happen, and they know how to manage it. So you had that resource. It's just an important reminder to be in touch and established with all of our primary care physicians, any specialists we have, our pharmacists at the pharmacy, or if you're working with a pharmacist here at Desert Oasis, and know where your nearest immediate care or emergency room is. And maybe even have those things up in your house so that other people can help you as well.
Well, and I hear people say, well, the immediate care, when it was something like that, there was no waste of time. When we walked in and we said he was in the back and they had him hooked up to check. But it was so, they're like, well, they're looking at this. So the immediate care, they're set up for everything.
They definitely triage and prioritize.
Yes, they do.
Yes. And thankfully for Brian's sake.
Yes.
Have you had any other interactions with other clinicians or specialists that maybe Stephen or Dr. Sebti have sent you to?
Well, we have seen, Dr. Jardula in the beginning with Brian's diabetes. We've seen Dr. Ali. She's the endocrinologist. We've seen cardiology with my dad. The diabetes, the clinicians with the pharmacy with Brian before they had the stroke. I think he's been to wellness because he's retired. Everything is right here. We're very fortunate. Very fortunate.
Well, Brian is very fortunate that has a loving and well-informed wife. But that's the point. If a patient needs social worker, case manager, being helped if they live alone, all those resources are available.
Yes. Right. Social workers to help. We have them in home health, but we have social workers for people that aren't on home health, so that if you have those things that you've got questions, just call.
Right. So I wanted to add something into the stroke clinic is that it's not only the clinical pharmacist, it's the entire team and bringing it up all together. Coordination of care is really big, especially for a stroke patient. They might be having trouble with just walking or just calculation or cooking. They can't open a jar anymore. There's a lot of difficulty that comes, and there's multiple healthcare providers that are really needed to help all these disability that might be new for the patient. So these include physical therapy so that they are able to regain the strength back to be able to walk and whatnot. occupational therapists, so they can actually do the activities of daily living, whether it's eating, cooking, or just walking, doing laundry, and all of that. Many patients after the stroke event can go through that difficulties daily. Also, speech therapist is also big, has a big role for patient with difficulty with comprehending or enunciating or just getting things out of the brain. Even they can think of that word, but some patients cannot express that words anymore. Speech therapists are also perfect for that. Also, with difficulty swallowing that comes after a stroke, they can also look into that. There's also optometrists that I sometimes have the patient go to for vision issues, or vascular surgery is also big. If they have any blood vessel blockages that need some surgical intervention, I make sure that those are considered if a patient has, let's say, 70% blockage in their carotid artery here, or like in the vertebral artery in the back. Some patients even can go through a surgery, although it's not generally done. Like, you can even go through that step to, if it's significant, I just make sure that they get the right team members involved, and I'm not here to do everything, nor do I know anything. I can't say that I know everything about stroke. So that's why it's very, very valuable, our relationship with Dr. Sebti neurology, with Dr. Porter as well, that I'm able to ask them questions at any time. So today I sent to Dr. Sebti 3 messages for 3 different patients. It's an abnormal day. I promise I don't bother him all that much, but I utilize him a lot so that I'm able to triage more complicated patients that I don't have answers to in regards to neurological deficits or cognitive issues that's not really explained or well explained by me, would be going directly to him. So I'm not trying to be a replacement for any primary care doctors or neurology. I'm here to really help out as fast as possible, get the risk factors under control, and then coordinate all of these, send the referrals for physical therapy, send it to cardiology if I feel like it's a cardioembolic, meaning that the stroke may have happened from the heart, which affects about 20 to 25% of the clotting type of stroke. I directly talk with our cardiology provider who's right next door to us. We share the same building, walk over there, ask them, I think they might be beneficial to have a heart monitor done so that we can roll out that if they have a condition called AFib that causes stroke for a lot of these patients. So a lot of getting the right team members involved is very crucial, and I'm happy to help the coordination as well as just helping to reduce the risk factor. So I just wanted to make it clear that I'm not here to kind of replace or substitute suboptimal, or my goal is to optimize the patient's care for the stroke clinic, and it's not to just help out and just redirect things from neurology and just help out his time, but also make sure that all of these are helped out in a timely manner.
Yeah. What you do, Stephen, no one else can do. You actually coordinate. I know you said cardiology provider. Basically, that means a heart doctor. So one day you called the neurologist, contacted, and you also contacted the cardiologist for the same patient, and you do all that. And I don't know what else this has been done, but I can tell you this is invaluable. Unless you're in the hospital and all these doctors can come to you, it's very difficult in outpatient. So what you do is fantastic, and no one can do what you do. So that's excellent.
It sounds like this is one example of the types of teams that really exist within Desert Oasis.
Yes.
Mm-hmm.
It takes a team of all of these different licensures and professionals and support staff. And, this is our newest version of that teamwork. And you guys have done amazing work. And
Yes.
I want to thank you for being here, and Tracy for being here as well.
Thank you, because this is very important. So I'm glad it's getting out there.
Thank you, Tracy, for joining us.
Well, that's a wrap for today's episode of Studio DOHC Podcast. I hope you found our discussion about the DOHC Stroke Clinic and the importance of recognizing stroke signs both informative and engaging. A big thank you to our wonderful guests, Dr. Sebti, Dr. Kim, and Tracy, for joining us and sharing their insights. If you enjoyed today's episode, don't forget to subscribe, like, ring that bell for alerts, and be sure to check out our other podcast episodes. Until then, take care of yourselves, and remember, knowledge is the first step to better health. Thanks for tuning in.